Hello class, I'm going to begin this online lecture with week 7, day 1, and our concept is nutrition with our exemplar of normal versus abnormal nutrition. First of all, what I want to do is go over the PowerPoint here on normal versus abnormal nutrition. And one of the things that we do have to look at, because it has been brought up quite frequently during many of these lectures, and it has been presented as a risk factor for a lot of illnesses and chronic diseases, is obesity. And obesity is defined as weight that is higher than what is considered as a healthy weight for a given height, and this is what we describe as someone being overweight or obese. And it's based on body mass index, or BMI, and it's used as a screening tool for determining if someone is overweight or obesity, and this follows the guidelines on the CDC website. And body mass index is a person's weight in kilograms divided by the square of height in meters. And a high BMI can be an indicator of high body fatness. And this next slide just kind of tells you where your BMI would be and what kind of range it falls in regards to your weight. So if your BMI is less than 18.5, it falls within the underweight range. If your BMI is 18.5 to less than 25, you're actually within the normal weight range. Anything 25 to 30, it falls within the overweight range, and then anything over 30 falls into the obese range. And please just remember that BMI does not measure body fat directly, but research has shown that BMI is moderately correlated with more direct measures of body fat, and we can obtain that from skin fold thickness measurements, bioelectrical impedance, underwater weighing, dual energy X-ray absorptiometry, which is also DXA, and other methods. And BMI appears to be strongly correlated with various adverse health outcomes, consistent with those more direct measures of body fatness. Be sure that you read over in your Pearson book about obesity. It talks about how it is an excess of adipose tissue, and it really is one of the most prevalent and preventable health problems in the United States. And because someone may have or be considered obesity, it really does have very serious physiological and psychological consequences, and is associated with increased morbidity and mortality. And research has also shown that with obesity comes a poor health-related quality of life, then do things such as smoking, excess alcohol use, and even poverty, which I found to be absolutely staggering. And your book talks about all the current national data on obesity with both adults and with children. It talks about adults that are age 60 and over are more likely to be obese than younger adults. And with women, 42% of those age 60 and older were obese, compared to 31% of women who were between the ages of 20 to 39. And I think it's important to kind of understand how someone does become obese. Obesity does occur when there's an excess calories, which are stored as fat. and it can result from excess energy intake and decreased energy expenditure, or even a combination of the two. And obviously, our nutrition, the foods that we take in, truly affect obesity. And we kind of call that our appetite, which affects food intake, and that's basically regulated by our central nervous system and, of course, by our emotional factors. It's important to kind of remember where that hunger center is. It's in the hypothalamus, and it stimulates appetite in response to stimuli such as hypoglycemia. When that blood sugar starts to drop, it signals the brain that it's time for us to eat. And as those nutrient levels rise, the satiety center sends the message for us to stop eating, and GI filling and hormonal factors also help to reach that level of satiety where we're satisfied and we don't want to eat anymore. However, appetite may have little relationship to hunger, and some individuals eat to relieve depression or anxiety, or others use it to promote feelings of well-being. There are hormones that are also involved in regulating obesity. Your thyroid hormones, insulin, and leptin, which is a peptin produced by fatty tissue that suppresses appetite and increased energy expenditure. Now, why are some people obese and others are not? It may have to do with some of the risk factors, and heredity may contribute as much as 25 to 40% of the risk of becoming obese. We also have to look at the physical activity of an individual, and research has proven that physical inactivity is probably the most important contributor to obesity. Even when a person tends to eat less calories, they continue to gain weight because of a lack of energy expenditure. Also, cultural and environmental factors, such as all the many labor-saving devices that we have in today's world, may also contribute to a lot of the sedentary lifestyle that we pretty much exhibit. A lot of us watch a lot more TV than we should, which is another major contributor to the increase in obesity, especially among children and especially among adolescents and the older population. Also, it's been seen that socioeconomic status tends to correlate with the risk of being overweight or obese. Women who have low incomes or low educational levels are more likely to be obese than those that have higher socioeconomic status. So how do we prevent ourselves or from our loved ones from becoming obese? I think that all begins with birth. Begins with, parenting. I think it begins too with how is that infant or newborn going to be fed? Is it through bottle or is it through breastfed? Also, it's setting a good example for parents as children begin to grow up. Parents should be encouraged to promote good nutrition in the home and engage in family-style dining, limit television and other behaviors that just keep the person from just sitting and kind of staying around. Your book also goes on to talk about some of the clinical manifestations. I won't go into that. I'll let you read through that. But sometimes I think we tend to judge people on the size that they are and tend to think that obesity is just mainly dependent on the amount of food one eats. But obesity is shown to have many contributing factors, and its treatment is far more complex than just reducing the amount of food that someone eats. A lot of the experts recommend an individualized program of exercise, diet, and behavior modifications help to meet that patient's specific needs. Sometimes when we see patients who are what we call morbidly obese, where their BMIs are over 40 or they're 200% of their ideal body weight, they just aren't able to lose that weight through diet and exercise, and many times may need some surgical intervention such as bariatric surgery. Now, what are those complications of obesity? And I think that's really important to look at. The one thing that we see very much associated with obesity is that metabolic syndrome, where a patient presents as increased waist circumference, hypertension, elevated blood triglycerides, and fasting blood sugar, and even low high-density lipoproteins. A lot of them do have what we call cholesterolemia or high cholesterol levels. And we have high of the bad cholesterols and low of the good cholesterols. And this syndrome is definitely a risk for someone to develop atherosclerosis and coronary heart disease. And also, we've known that obesity does contribute to sleep apnea and can also contribute to the risk of heart failure. There are some diagnostic testing that could be done. And of course, the first one is the simple, just calculating one's body mass index. And another one is anthropometry, which includes measurement of height, weight, waist circumference, and waist to hip ratio. And then there's also underwater weighing and bioelectrical impedance. There can also be labs that we do to see if this is a metabolic problem or a physiological problem as to why someone may be obese. We might want to see and assess a patient's thyroid panel, serum glucose. Do they have the all dreaded diabetes, serum cholesterol, lipid profile, and of course to do an electrocardiogram on the patients. We all know that exercise and physical activity is really a essential lifestyle habit to obviously make yourself do every day, to help yourself lose weight, and also to keep that weight off once you've lost it. Many times in the beginning, we see patients with obesity may experience excessive fatigue, tachycardia, and shortness of breath with activities. And these symptoms result from that physiological effect of excess weight as well as a sedentary lifestyle. It's really important if someone wants to begin to exercise and they haven't for a while to really be assessed and checked out cardio and pulmonary wise before they begin and participate in an exercise program. It's really recommended that an aerobic exercise program of about 30 to 40 minutes a week of exercise 5 or more days a week promotes weight loss while reducing adipose tissue and increasing that lean body mass and promoting long-term weight control. Again, another aspect of keeping your weight under control is nutritional management. Really what we don't want to see is that term that's mentioned in your book about yo-yo dieting, where people, tend to go on these particular kinds of diets, they lose weight, and then they gain it back. There's also very low calorie diets, and those are generally reserved for patients who have BMIs greater than 30. And then looking at behavior modification. And sometimes it might be a good idea just to have a journal and keep track of some of the foods that you eat, to kind of look at what pattern of foods that you're eating. Because sometimes we don't realize how many times we go into the cupboard or into the refrigerator and pull foods out and start to kind of snack and eat them, and don't realize that we're taking in all these calories. And it really is time to kind of look and see what your eating behaviors are. There's all kinds of social support out there and group programs. I think people have participated in and been very successful at Weight Watchers, Overeaters Anonymous, and Take Off the Pounds. Surgery is also an option for those morbidly obese patients, and we call that bariatric surgery. Probably the most common types of bariatric surgical procedures are gastric bypass, or the sleeve gastrectomy, which 80% of the stomach is removed, or an adjustable gastric band surgery, and a combined restrictive and malabsorptive or absorptive surgery such as the Roux and UI. So that's just a little recap of obesity and how serious that condition is, which can lead to a lot of very unhealthy diseases and really affect quality of life, as well as the length that someone may live. We also know that there are a lot of eating disorders out there, and one that you may be familiar with is anorexia nervosa, and that's also often simply called anorexia, where it's an eating disorder that's characterized by an abnormally low body weight, intense fear of gaining weight, and a distorted perception of your own body weight. And people with anorexia place a high value on controlling their weight and shape, using extreme efforts that tend to significantly interfere with activities in their lives. And they are so obsessed with gaining weight that they begin to severely restrict the amount of food they eat. They may eat food and then follow it with vomiting, or they also may misuse laxatives, diet aids, diuretics, or enemas, or also they may just try to excessively lose weight by exercising excessively. And no matter how much weight loss they achieve, the person with anorexia still has an intense fear of gaining weight and continues to think that, I'm really, really still very fat. Then we also know patients who suffer from what we call bulimia. They secretly binge, they eat large amounts of food, and then they purge, trying to get rid of the extra calories in a very unhealthy way. And for example, someone with bulimia may force vomiting or engage in excessive exercise, and sometimes people purge after eating only one snack or a normal-sized meal. They just have a lot of guilt and feel that that food is going to cause them to unfortunately gain weight. And of course, we might see the terms purging bulimia, where they regularly self-induce vomiting or misuse laxatives, diuretics, or enemas after binging. And non-purging is they may use other methods to rid self of calories and prevent weight gain, such as fasting, strict dieting, or excessive exercise. Now, I know there's a little bit of information on this PowerPoint on celiac disease. Just a reminder, Dr. Joris has provided us about a 5.5-minute video on celiac disease, because we do see this very often in pediatric patients. They develop this early in life. It is a disease where they're unable to digest glutein, And remember, gluten is a protein that we find in any product that has wheat, rye, oats, and barley. And this gluten is broken down into this gliadin in the small intestines. And with celiac disease, you aren't able to break that down. So, of course, you have this accumulation of glutamine, which has a very toxic effect on the mucosal cells. And what it does is eventually causes atrophy of the villi, malabsorption problems of fat, calories, carbohydrates, and vitamin deficiencies. And when these people go into celiac crisis, it presents with extremely severe dehydration and diarrhea. It is an inherited ability to digest gluten. It's a malabsorption syndrome, has some familial tendency and disease. It's most common in Caucasians and cause unknown, thought to be a problem of metabolism. Usually it's diagnosed in young children between the ages of 12 and 18 months, and treatment is to avoid gluten in their diet. And as we look at some of these malabsorption disorders, these are usually conditions in which the intestinal mucosa ineffectively absorbs nutrients, resulting in their excretion in the stool. And as I said, this is one of those specifically that we've talked about, which is celiac disease. And remember, if you go back and remember about your anatomy and physiology, but most absorption of nutrients occurs in the small intestines. And remember, the mucosa of the small intestines is pretty much set up where they're like in a microscopic fold, which in turn contains even smaller finger-like projections called villi. And the cells of the villi are covered with microscopic hairs, which are called microvilla, protecting from the cell membrane. And these folds or villi of the intestinal mucosa provide a huge surface area for nutrient absorption. And cells of this intestines are specialized to absorb these different nutrients. But in celiac disease, this intestinal mucosa is extremely damaged by, unfortunately, an immunologic response. And then this gliadin acts as an antigen, which is a substance that induces the formation of antibodies that pretty much attacks its own self. So people that have celiac disease will have increased antibodies to other antigens as well. And so what happens is this immune response prompts and stimulates an inflammatory response in the small bowel, which causes the destruction or the loss of these villi and microvilli. And these little hair-like fibers will start to atrophy, resulting in a loss of these intestinal folds. And with the loss of them, intestinal absorptive surface is lost, and production of digestin enzymes, including disaccharide and particularly lactase, is reduced. And then that proximal small bowel is affected to the greatest extent, likely because of its greater exposure to that dietary gluten. So who gets celiac disease? The cause of celiac disease is unknown. However, there is some genetic predisposition and immune factors that play a role in someone to, unfortunately, getting it. And the one thing that you want to understand is how does celiac disease presents? There's abdominal bloating, cramping, diarrhea, and steatorrhea. And unfortunately, there's a lot of nutrient deficiencies. Anemia is common. Patients who do have celiac disease are very small in stature and may have a delayed maturity. And other signs may include tetany, vitamin deficiencies, muscle wasting, and rickets, which is impaired bone development. When gluten is removed from the diet, the manifestations of this immunological disease will typically resolve. GI malignancies and intestinal lymphomas are potential complications of celiac disease. So how do we diagnose celiac disease? Lab and diagnostic testing are used to make the differential diagnosis for various causes of some of these malabsorption problems. An enteroscopy permits a direct examination of that intestinal mucosa, and they'll also obtain a specimen to look for it under the microscope and to do a tissue specimen for biopsy. And a tissue biopsy is necessary to actually establish and make that diagnosis of celiac disease. They also may do an upper GI series to kind of look at the structures of the small bowel. And what they see with celiac disease is this typical feathery patterns of barium in the small bowel is lost, and the barium may precipitate and clump. Laboratory tests that might be used to identify the pathophysiological effects of the disease may be fat content in the stool is definitely increased. Fecal fat is measured to document the presence of steatorrhea, which is presence of fat in the stool. And some of these antibody testings may also be done, as well as protein levels, albumin, cholesterol, electrolytes, and iron. When people do develop celiac disease, there may be the need to provide supplemental vitamins and nutritional supplements to kind of counteract what's been lost as far as the absorption. And of course, with nutritional management is probably one of the most important ways to be able to manage someone who has been diagnosed with celiac disease. And this is someone needs to be now on a gluten-free diet. So that's just a little more information about celiac disease. So be sure and read your sign section in your Pearson book, as well as listening to Dr. Joris's video. I also want to encourage you to read the article that's in Canvas on obesity. The first line has to do with obesity is an epidemic among adults as well as children and adolescents in the United States, and the current recommendations from the Endocrine Society focus on the prevention, the diagnosis, and management of pediatric obesity. I'm not going to read that to you. You all are very capable of doing that on your own, but be sure you do. There may be some test questions taken from that. Obviously, we're going to look at some of the highlights of that article, but again, reinforcing and really stressing how serious obesity can be in regards to a person's health. Class, what I wanted to kind of go over with you, and we would have done this activity in class had we been in class for these 8B, but on Appendix 51, we're looking at nutrition labels, okay? And I would have had you bring in a label so we can kind of discuss them. And they didn't necessarily have to be a healthy food. I just wanted you to bring in a label. I wanted you to kind of get that awareness of what is on that label. Because we need to teach ourselves and our patients about what is in the foods that we are eating on a daily basis. And this is extremely important for people that may have diseases that are very much affected by the foods that we eat. So right here I scanned a food that I had in my pantry, and there are those Tostito corn chips. And as you can see in front of you, I do have the label for you to kind of analyze. So there is approximately 13 servings in this bag of Tostitos, okay, and they consider one serving 7 chips, which isn't very many. And I know many of us, when we go and dip our hands into these types of snacks, we probably eat more than 7 chips, okay? So 7 chips are about 140 calories. And now it goes into talk about how much fat, whether it's a saturated fat or are there any trans fats, and those are the bad ones. And it's about 1 gram of saturated fat, and total fat is about 7 grams. There's no cholesterol, a lot of salt, 115 milligrams. Total carbs, 19 grams, which makes sense. A little bit of fiber, not much, 1 gram, but no sugars, and a little bit of protein, 2 grams. And then there's some additional listing of nutrients such as vitamin D, calcium. There is some calcium in these chips, 25 milligrams, and no iron, and a little bit of potassium. And not a significant source of added sugars. And then at the bottom, as you can see from this square, there is a addendum that says ingredients: corn, vegetable oil, corn, canola, and or sunflower oil, and salt. So there doesn't seem to be anything really horribly wrong with this food. Not a whole lot of preservatives. Is it nutritious? Probably not too much, but it can't satisfy that craving. But I think we have to understand is, look at the servings per the container. They consider 1 serving 7 chips, which isn't very many. And so I think that's where we get into trouble with calories, because we kind of tend to overdo the portion size. So I think we need to be better label readers, especially to understand exactly what is in the foods that we're putting in our mouth. And I don't think you're ever too young to start eating in a healthier way. I know we're never going to do it perfectly, but it's kind of interesting to look at these labels and see exactly what is in this food. Okay, so I have another one I'm going to pull up for you. Now this might be a common food. I have these in my pantry. I'm not too very fond of this food, a Pop-Tart, but I have them in there for when my grandkids come over. As you can see, it's both in Spanish and English. All right, and so this box has apparently 12 servings or 12 Pop-Tarts. So they're looking at 1 pastry or 1 Pop-Tart. And each one of these Pop-Tarts is 210 calories. And total fat is 7 grams. Saturated fat, 2.5. There are no trans fats in the Pop-Tart. And polyunsaturated fats, about 2.5 grams, and monosaturated fats are about 1.5 grams. No cholesterol, sodium's about 170 milligrams, and total carbs are about 35. Dietary fiber is really insignificant, less than 1 gram, but there is a fair amount of sugar, 15 grams, and about 2 grams of protein. Talks about all the vitamins, if there are any, within that food. And then it's on the right hand side of that, you can see where, look at the top, it is in English, talks about what other ingredients are in the Pop-Tart. And sometimes it concerns me when I can't even read the particular ingredient. It's very concerning to me. But look at right here, you'll see it says high fructose corn syrup, and that's very, very bad. Those are things that lead to coronary artery disease. So this is not a very healthy food, even for children or an adult. Just a lot of empty calories with a lot of things in it that really are not really good. So just a little example then of food labels and how I want you to, in your own personal life, really get in the habit, especially when you're at the grocery store, to read these labels and look at what that additional ingredients are, because this is the kind of stuff that you are able to find out is in that food, the bad things such as high fructose corn syrup. So this is kind of fun to do as a class, but unfortunately we couldn't do this, but I wanted to give you a little bit of this now, so I scan these for you to kind of be more aware of the kind of foods we eat and what's exactly in our foods. So that's what Appendix 51 was about, just looking at all the recommended dietary intake of sodium, sugar, protein, saturated fats, carbohydrates, and definitely just how many calories that you're taking in. There were some handouts in your lesson plan with these appendices, and according to the American Heart Association, the maximum amount of added sugars you should eat in a day is about 37.5 grams for men and about 25 grams or 6 teaspoons for women. And the United States Department of Agriculture recommends that all men and women over the age of 19 should get at least 0.8 grams of protein per kilogram of body weight. And this comes out to about like, say for instance, if a woman is around 130 pounds, she should get about 48 grams of protein. Okay. And then the American Heart Association recommends aiming for a dietary pattern that achieves about 5 to 6% of calories from saturated fat, which isn't many. So for example, if you need about 2,000 calories, then no more than about 120 of those calories should come from saturated fats. So that's about 17 grams of saturated fats a day. And you saw what we had on some of those food labels. So you'll be able to get that information from your food labels. So again, wanted to bring that to your attention. So women get between 40-45 grams of protein a day, and men get about 50 to 60 grams of protein a day. Very important nutrient to obviously get in with the foods that you eat. Okay. All right, so let's look at Appendix 52 when we kind of look at foods from different cultures. I have here an analysis of some dietary cultures, and the first one we have are the Mexican culture, and here's just a kind of a presentation of what types of foods that this culture would be eating. And the Mexican culture possesses an extensive and sophisticated culinary culture with a great variety of regional dishes. Corn, hot peppers, and beans are 3 products that constitute the heart of most Mexican dishes. This culture uses over 100 different types of chilies, which range from large and sweet to small and extremely hot. A Mexican diet starting with breakfast may begin with coffee and fruit. By morning, a warm tortilla-based snack is added, and the most important meal of the day is served between 2 and 4, consisting of 3 or 4 courses. Could have soup, rice, pasta, meat, and chicken, if they can afford the meat, and it may accompany tortillas, refried beans, and dessert. Dinner is between 8 and 10. It may involve sweet rolls, coffee, and milk, and Mexicans like to eat outdoors frequently, drink beer and soft drinks. National liquor is tequila, and food customs are often seen at ceremonial Mexican occasions. Then we have the Japanese culture. Has an obsession with food. It is much about the prep as well as the presentation. Presentation and preparation of food in Japan looks like a work of art. Chefs bring out the color and flavor of the food, so do as little as possible with it, and the Japanese cuisine is one of only 3 national food traditions recognized by the UN for its cultural significance. Tempura is a highly popular way of preparing vegetables or seafood, and these foods are covered in a light batter and deep fried. The takoyaki, grilled or fried octopus, and sushi are popular dishes in Japan, and sushi is a dish of rice cooked with vinegar and topped with seafood, and if uncooked, it is made into rolls. Rice is served at every meal. There is an infrequent use of garlic, chili peppers, and oil, and foods are seared, broiled, or even eaten raw, minimally seasoned. Miso, soy sauce, mushrooms, seaweed, and bonita flakes are added to some foods to enhance flavor. Condiments such as light dipping sauces, citrus miso, wasabi, pickles, and soy sauce may also be used in preparing the Japanese cuisine. The dishes that the food is served on are very important in the Japanese culture, and the seafood industry is huge along with vegetables. In the Japanese culture, it is rude to leave a messy plate after eating. Tea with meals is seen as an art. So that's our Japanese cuisine. Then the next one is the Mediterranean. Okay. And let me go back to that. Sorry, I'm trying to get this situated. The Mediterranean diet is centered on the olive, wheat, and is centered on olives, wheat, and grapes. It is a plant-based diet consisting of whole grains, fruit, vegetables, herbs, spices, beans, nuts, and olive oil. Eating within this culture is a time and place for interaction raised to the level of religion. Rarely is red meat eaten. There is a moderate intake of poultry, eggs, cheese, and yogurt, and the culture partakes in drinking moderate amounts of wine with their meals. This is supposedly one of the very healthiest diets because you don't have a lot of red meat, which has a lot of cholesterol in it, and it's more of a plant-based diet. African American, the cuisine of this culture consists of fried chicken, macaroni and cheese, collard greens, breaded or fried okra, and cornbread. Side dishes are hush puppies, ham hocks, and black-eyed peas. And another favorite is chicken fried steak, giblets as chicken livers and gizzards. Ham and bacon are used plentiful in flavoring and in gravies and sauces, and grits are an African American favorite, along with the finishing touch of a cobbler, pecan pie, or sweet potato pie. So I think if you look at these 4 different types of cultural meals, we could answer these questions pretty clearly, discussing each diet and determining if it represents a healthy diet. I think some are better than others, obviously the Mediterranean, and somewhat the Japanese as well. Does it provide all the necessarily daily requirements for healthy adults? It can, as long as they're getting all those proper nutrients of protein, a balanced amount of protein, carbohydrates, and fats. And do any of these diets contribute to chronic diseases as CID, hypertension, and diabetes? And I think some of these you could answer yes, especially with the Mexican diet, and of course with the African American. A lot of fat, a lot of salt, high sodium. What diet would be implemented for weight loss? And I think we could use somewhat of the Japanese as well as some of the Mediterranean foods. And you also have to look at the financial factors of them as well. With the African American, I think those foods are obviously less expensive as compared to the foods in the Japanese culture, which can be highly expensive, and even some of the meats that maybe the Mexicans want to use or cook with as well. So I wanted you to kind of get aware of that. Again, going back to culture and knowing that it's very difficult for some of our patients who are diagnosed with diseases that rely very heavily on their diet to be able to control that disease. It's very hard for some of these people to step back and kind of modify or reinvent their diet, that it adheres to their culture, as well as to hopefully get them on a better road to eating healthier, to be able to control their diseases that unfortunately are illnesses that make it necessary that they really do change their diet. So reread those again and kind of ask yourself these questions. I've given you some answers to some of these, but really, kind of analyze them a little bit more closely and determine which one would probably be the best one to adhere to. That's why you see people with, that live in the Mediterranean area really do have less prevalence of cardiovascular disease and things like hypertension and obesity as well. All right. All right, the next thing I want to do is talk over this case study with this child, Stacy Carpenter. Excuse me. Let's kind of go over this and think about some of the problems that this young girl is definitely facing. So we have Stacy Carpenter, who's a 9-year-old Hispanic female who was seen in the pediatric clinic today for a well child checkup because she wants to play softball in the fall. She weighs 120 pounds, which places her at the 120th percentile for weight. She is 55 inches tall. Her blood pressure is 130/90 and her heart rate is 90. Stacy's mother, is visibly overweight, and Stacy's mother knows that obesity is a problem in many school-age children today, and asks for help in changing Stacy's diet, her lifestyle, and weight loss strategies. The nurse asked Stacy to do a quick 24-hour food recall, and Stacy identifies the following. For breakfast, she has 2 Pop-Tarts, a glass of chocolate milk, and 1 glazed donut. For lunch, she has 2 slices of pepperoni pizza, 2 breadsticks, 1 serving of canned peaches, a bottle of fruit juice, and a sugar cookie for dessert. And for dinner, she has 3 chicken enchiladas, Mexican rice, refried beans, chips and salsa, and 2 sopillas. So when the nurse asks about exercise, Stacy says she really does not do any exercising except for recess at school. So wow, look at this food that this child eats. Isn't it funny? We just got done looking at the Pop-Tart labels. So makes us more aware of how non-nutritious that particular breakfast food is, because again, then she has a glass of chocolate milk and she has a glazed donut, so a lot of sugar and calories. She begins the day with her breakfast meal. All right, so let's look at these questions. So in evaluating Stacy's diet, what findings would concern the nurse most, and what findings concern you? Because you're the nurse now, so what bothers you the most about this child's diet? Well, I'm very concerned about all the high carbs that she's eating, lack of protein, excessive calories, and a lot of foods that are very deficient in nutrients and vitamins. So number 2, why might Stacy's blood pressure be high? Well, obviously a lot of reasons. She's first of all extremely overweight, she doesn't exercise, and she has increased sodium intake, and of course her ethnic background makes her more vulnerable to hypertension, being that she's Hispanic. So what role, if any, does Stacy's ethnicity play in her weight problems? We do know from way back when we talked about culture, Hispanic Americans are at greater risk for obesity, and those traditional diets, just like we went over prior to this case study, are very high in calories. So what could be the cause of the elevation of Stacy's blood pressure? Well, obviously her obesity, which we've already talked about. What else? Think about it. And of course, all her high sodium intake as well. Really increases that vascular volume, making more of a workload on the heart. All right, so let's go to the next question. Should Stacy's mom be concerned, and what should the nurse teach her at this point? She should be very concerned as a parent. Stacy is significantly overweight, and her diet is high in calories and very poor in nutrients, very much lacking the important things that she needs for good growth and development. She is at risk for the development of type 2 diabetes, and her blood pressure is elevated. The nurse should teach Stacy and her family the importance of activity and refer them to a dietitian for more of good meal choices and preparation. So let's continue with this case study, okay? So Stacy returns to the clinic 6 months later with complaints of feeling tired and having a sore throat. Stacy's I don't know why that's doing that. Stacy remains at the 120th percentile, and her mother relates that Stacy is also being followed for elevated blood sugar. Her blood pressure is 136/92. Stacy and her mom reports that Stacy has not really changed her diet and that she is exercising some, but she really enjoys her video games and staying inside. She was not successful at her athletic events because she could not run fast enough, and a diet history is similar to that reported in her first visit. So what are the priorities of for care for Stacy at the time? I think the first thing we need to do is get her to change some of the foods that she's eating. Let's stop and help plan some dietary menu that will that Stacy likes and that she's going to follow, and that also has some of the nutrients that this child needs, also with a reduction of calories. And we got to get her to exercise, even if it means just walking up to the corner and back. So what interventions might be appropriate for Stacy? Finding a way that she'd like to exercise. Maybe if there's a indoor pool from a recreation center in her area, that might be a great way to begin exercising. At this point, it might be important to include some friends to hold Stacy accountable, and also friends that would want to exercise with her. What risk, if any, does Stacy's blood sugar have on her overall health? I mean, it's a huge risk. Her high blood pressure can lead to heart disease, to eye disease, and obviously to kidney disease. And question 4, what lab test would you expect the practitioner to order? Probably they're going to do a host CBC and DIV, serum cholesterol and lipid profile, a chem profile, and let's do a baseline EKG on her as well. And what resources are available to help Stacy's mom with meal planning and food selection? And I think a dietitian, either at the school or even at the hospital, okay? All right, let's go to part C. Stacy comes to the nurse in the clinic at her school. She tells the nurse about her feelings, about her weight, and her need to exercise. She's lost 7 pounds but cannot seem to lose any more. She asks the nurse to help her develop a diet plan for 3 days, considering she eats breakfast and lunch at school. So, how would you follow up with Stacy? Definitely have the child do a diet recall for the past 3 days. Remember, we talked about ways in which we can kind of look over the diet that the person is, following each day. And it's pretty easy to kind of go back and remember what you ate in the last 3 days. Remember, she could also review the MyPlateGov site with Stacy and begin to teach her about nutrition, okay? Question 2, how would you encourage exercise? I think we could use positive and reward reinforcement. Stacy can begin with activities that just start off very slowly, such as walking, maybe swimming, because that might also be fun as well and wouldn't be as boring. It might be possible to get Stacy involved with other athletic activities at school. And Stacy should develop a chart where she kind of writes down what she does every day with her exercise and then reports that back to the nurse. All right, question 3. What role should the school play in providing options for food choices? The schools are now trying to do a lot better with the foods that they give the kids, and they're really providing more healthy lunch programs, and they could also provide some healthy meals after school. in those after-school programs. Question 4, what plan would you develop for Stacy? Stacy should have a plan for monitoring food intake and activity. She could use a program by which she calculates the calories in all of her food choices. Make it fun, make it a little bit of practicing her math, and teach her how to take her pulse, doing it over 15 seconds, telling her to multiply by 4 so she could kind of add some of her other classes that she takes at school and make it kind of a game as well. And what teaching would you perform at this time? I would talk to her about how serious obesity is and how it's going to affect her quality of life. And I wouldn't necessarily tell her this, but I worry in the future about peer pressure, that people may begin to make fun of her as well. But I'd surely begin teaching her the problems she could see with her weight being so much and the fact that her blood pressure is so high. So again, teaching her about the relationship between elevated blood pressure and heart disease and the importance of exercise in relationship to decreasing that blood pressure. So how would you include Stacy's peers, and if so, how would you involve them? I would ask the girl first, Stacy, if she wanted them included, because she might be embarrassed about the way she looks, and especially if these friends of hers do not have a weight problem, she might feel very insecure to be around them. So maybe let's just work with her on an individual basis until she's ready to involve her friends, because you don't want to affect her mental status and have her get down in the dumps and, be embarrassed or ashamed by what she's doing. So these are some of the things that we do see with children out there, the problem of obesity and how it does kind of have a snowball effect on bodily processes, where blood pressure is affected, blood sugar is affected, and just her whole quality of life is affected. Continuing with our concept of nutrition, we are just going to present an introduction to electrolytes, and I do have a PowerPoint here for you, and then we'll go over some practice questions. I can't tell you the importance of understanding about electrolytes and about fluid balances, okay? Because many of your patients who do have underlying disease processes will possibly have fluid and electrolyte imbalances, and so it's very important to understand when you as the nurse need to be concerned and what kind of manifestations you're seeing with your patient, which could signify or tell you that, hey, the patient has some kind of hypo or hyper of that particular nutrient or electrolyte or whatever. So we have to realize the importance of this, because when our patients do come into the hospital, this is pretty much a part of their standard labs where we look at electrolytes and then obviously assess their hydration status as well. So I really want you to pay attention to this. We're just introducing electrolytes, but I'm going to try to kind of reinforce and kind of elaborate on the ones that I think that you should really be aware of that really do affect the quality and your patient's health. Now in Nursing 100 we did talk about water, how important water is, and I've said many times that we can live without food for probably up to a week or a couple weeks, but we can't live without water more than 2 or 3 days. It works as a solvent, eliminates waste through the kidney, skin, and lungs, the GI tract, assists with temperature regulation, and it helps as a lubricant for joints. Remember these compartments that have to do with where fluid and electrolytes are more plentiful at. You have your intracellular, which is inside the cell and comprises about 40% of your total body weight. There's a larger amount of potassium, magnesium, and phosphate within the cell. Outside the cell, This is that intravascular fluid, your vascular space, and your interstitial fluid. That's between the cells and outside the blood vessels. And this is about 15% of your total body weight, 20% of a total body weight. Larger amount of sodium, bicarbonate, and chloride and calcium. And a lot of our bodily processes and the movement of bodily fluids go across cells and capillary membranes, and that's accomplished by these processes of osmosis, diffusion, filtration, and active transport. So let's look at each one of these individually. And a lot of this is review. You've had a lot of this in some of your science classes, your anatomy and physiology, your osmosis, but I want you to look at these processes more and how they relate to the human body, and not just a scientific term that you may have to kind of look at when you're in a biology or chemistry lab. What do these processes do for a human being? We see them occur within the body for these bodily processes, metabolic processes. So think of it in those terms, okay? So osmosis, it's the movement of water across cell membranes from less concentrated solutions to more concentrated. And we talk about solutes like crystalloids and colloids because you're going to be taking care of patients who are going to have those types of solutions ordered. And what do we mean by crystalloids? That might be an IV solution, okay? And colloids might be, maybe you're going to give your patient albumin. That's a colloid because it is a type of solution or a solute that's going to help expand vascular volume. Maybe you would give that for a patient who is bleeding and we don't have an available blood product on board, so we give them a colloid. The solvent is the component of a solution that can dissolve a solute, and it's important in maintaining vascular volume. And that's what I've talked about with you, especially when we talk about the importance of proteins and albumin and how it keeps all that fluid in that vascular space so it maintains good pressure and good perfusion. All right? So that's osmosis. And then we have diffusion, which is an intermingling of molecules, and the rate of diffusion varies by the size of the molecules, concentration of solution, and the temperature. And what have we always talked about which deals with diffusion is the diffusion of gases, the process of oxygenation of those molecules going across a semi-permeable membrane, and that's by the process of diffusion. And when our patients have illnesses that affect that diffusion of gases, there's where we could see a patient have problems, respiratory rise, where they have hypoxemia, shortness of breath, and definitely a lot of respiratory difficulty. So that's osmosis, diffusion, and then of course filtration. This is the movement of fluids and solutes together across a membrane from one compartment to another, from an area of high pressure to low, hydrostatic pressure, pressure of fluid exerted on walls in a closed system. Filtration is one of the processes that occur in making urine that happens within the kidneys. It's just like a coffee pot who filtrates those coffee grounds and only lets the fluid come through it, and that's the part of the making of coffee that we drink. We don't drink the grounds. That would be gross. Same thing happens within the kidneys. There's certain substances that go across that glomerulus, and so things are filtrated from it that then get excreted in the urine, and other ones get reabsorbed back into the vascular system. So that's what I mean when I say let's think of these in terms of what bodily process is occurring and where does that happen as to what particular system or organ does that occur in. And then active transport is substances that move across membranes from less concentrated to more concentrated, and this is where metabolic energy is expended. Maintains higher sodium levels in extracellular fluid, higher potassium concentrates in intercellular fluid. It has to do with that sodium-potassium pump. This is, again, a process that happens within the kidneys as well, okay? It's called active transport. Just trying to see. All right, so hopefully that'll make sense, all right? This is why you need to go back over this chapter in Pearson. That starts on page 357. I really want you to understand this, but now we're looking at it in terms of our patient, okay? So let's go over these electrolytes. What is an electrolyte? It's a salt that breaks into electrically charged ions in water. We have cations, positive charge, and anions are the negative charge. And electrolytes are measured in milliequivalents per liter, as in that parentheses, MEQ/L. Maintains the balance of fluid volumes, electrolyte compositions essential to health. So let's talk about the important ones, all right? Sodium. And these values you will know by, like your own name, when you begin to analyze these labs on your patients. Normal serum level is 135 to 145. Most abundant cation in extracellular fluid contributes to serum osmolality, regulates extracellular fluid volume and distribution. And that's sodium. It really does basically control regulating your water balance. And when sodium is reabsorbed from the kidneys, chlorine and water are also reabsorbed. Remember, wherever there's sodium, water follows. That's why when you think about yourself, you go to the movies one night and eat a whole barrel of popcorn. Even though you have normal kidney function, you might be a little bit puffy because where that sodium was that you kind of took in, water followed it, and you kind of have a little bit of extra fluid on you, okay? And we know that many of the foods we eat really do have high sodium. Think about foods like bacon and ham, and a lot of your frozen foods and a lot of your processed foods all have sodium in it. So this is why it's important to teach our patients about their sodium levels, especially if they have heart failure or they might have hypertension, okay? Usually a suggested amount of sodium is about 1,500 to 2,300 milligrams per day. And again, we can get that information from our food labels as to how much of a serving or how many servings out of that particular bag or box or can. We can determine how much approximately of sodium that we have taken in with the foods that we eat, okay? So that's sodium, very important electrolyte. And then potassium, serum, normal serum levels are 3.5 to 5.3 milliequivalents per liter, major cation in intercellular fluid, and maintains ICF osmolality, transmits nerve and other electrical impulses, skeletal, cardiac, smooth muscle function, regulates acid-base balance, and must be ingested daily. All right. And it really is absolutely a very, very vital electrolyte for skeletal, for cardiac and smooth muscle activity. And it helps a lot with intracellular enzyme reactions. You have to eat a continuous source of potassium because the body doesn't store it, okay? A lot of your fruits, vegetables, meat, fish, and other foods do contain potassium. This is an electrolyte that you got to keep an eye on, especially not only with all our patients, but particularly with patients who might have problems, cardiac issues, because with high levels, it makes the heart contract more, where they can develop arrhythmias. And, it's like getting a cramp in your muscle. Well, it's like getting a cramp in your heart muscle. So we don't want to see the patient develop any abnormal heart rhythms or arrhythmias. And many times we'll see patients develop deficiencies of potassium, especially when they're on diuretics or medications to help rid the body of fluids if they're in fluid overload. But this is one electrolyte that if we see that the patient has an abnormal value, whether it be high or low, should be reported immediately to your healthcare provider. Okay. Then we have calcium. Normal calcium level is about 9 to 11 milligrams per deciliter, mostly found in skeletal system. It's a cation. Skeletal maintenance regulates muscle contractions, especially the cardiac muscle, neuromuscular function, cardiac functioning, blood clotting, and activates enzymes. Okay. About 99% of your calcium is in the skeletal system, with a relatively small amount in the extracellular fluid. Okay. Calcium is regulated by kind of the togetherness or interactions between your parathyroid hormone and calcitonin, which comes from the thyroid gland. Okay. The problem with calcium as we begin to get older is the intestines will start to absorb less calcium, and more calcium is excreted by the kidneys. So this is why people will begin to develop osteoporosis. We know that milk and milk products are probably the richest or the best sources of calcium, and sometimes people need calcium supplements to kind of help with bone health as well. And again, I'm sure a lot of people don't realize it, but calcium is essential for blood clotting as well, and I wanted to definitely stress the importance of calcium in those regards. That whole process of blood clotting and hemostasis, calcium is an extremely important component in that process to occur. So that's calcium. All right. The next one that we want to talk about is magnesium. This is normal serum levels are about 1.5 to 2.5, found mostly in skeletal systems. It is the second most abundant intracellular fluid cation, intracellular metabolism for protein and DNA synthesis, operates that sodium-potassium pump, regulates cardiac neuromuscular function, and relaxes muscle contractions. A lot of your cereal grains, nuts, dried fruit, green leafy vegetables are a good source of magnesium as well. Okay. The next one is chloride. Serum levels are 95 to normal serum levels are 95 to 105. Major anion of extracellular fluid, regulates serum osmolality, regulates extracellular fluid balance, and helps with acid-base balance. Major component of stomach fluid, buffers in oxygen, carbon dioxide, and oxygen. All right. Remember, chloride is a major component of your gastric juices, such as what we know as hydrochloric acid, and is involved in regulating acid-base balance. It also is a buffer in the exchange of oxygen and carbon dioxide in red blood cells. And mostly chloride is found in the same foods that you would find sodium in. All right. And then phosphate. Serum levels are about 2.4 to 4.5 milligrams in adults, much higher in children. Major anion of intracellular fluid, forms bones and teeth. Metabolism of proteins, fats, carbohydrates. cellular metabolism, muscle nerve RBC function, regulates acid-base balance, and regulates calcium levels. Because remember, there's that inverse relationship between calcium and phosphorus. And so when one is up, one is down. When one is down, the other one is up. So that's what we mean about inverse ratio between calcium and phosphate levels, okay? And again, we get a lot of our phosphate from meat, fish, poultry, milk products, and legumes. And then lastly is bicarb, which we have already talked about when we kind of went over blood gases. It's found in both intracellular and extracellular fluids. It's a major body buffer, definitely in the process of regulating acid-base balance through metabolic processes. And the kidneys play a big role in regulating bicarb, okay? When too much is on board, the kidneys will hold on to it, or else reabsorb it or excrete it, depending on what that pH is, especially if it's a primary problem is metabolic. But again, it does work to regulate acid-base balance. Might be that other system, especially to help out the respiratory system, if that's not functioning properly. But again, that help may not come till a little bit later on. It doesn't always happen immediately. So those are the main electrolytes that I want you to, of course, go over. And again, review those bodily processes of osmosis, diffusion, filtration, and active transport. And looking at the term osmolality, which is the concentration of solutes in a body fluid. And why is that important? Because there may be certain solutions that your patients may have ordered, whether or not it's a isotonic, hypertonic, or hypotonic solution. So please go over those as to why a hypertonic or a hypertonic or isotonic solution would be hung on your patient. Again, looking at regulating body fluids when it comes to hydration versus dehydration, and the importance of fluid intake, and what should the average daily fluid intake for an adult be. Usually we should be taking in orally about 1,200 to 1,500 mLs of fluid, and our foods also have water, which amounts to about 750 mLs, and water as a byproduct of food metabolism is about 200. So about totally we take in anywhere from 21 to 2450. So please understand, exactly what happens with that. Again, when we're talking about fluid intake and fluid output, all right? And definitely maintaining homeostasis when it comes to some of the important hormones, especially ADH or antidiuretic hormone, which your book talks about on page 365, which really does help control water balance. And again, also many of the specialized receptors in the juxtaglomerular cells of the kidneys that are affected by renal perfusion, or are pretty much the status of hydration or how much fluid is in the vascular space. ANF is a peptide hormone released from cells in the atrium of the heart in response to excessive blood volume and stretching of the arterial walls. So that's another thing that I want you to look at that helps again to maintain homeostasis. All right. And continue reading through this chapter when we look at making that nursing assessment of our patients, and kind of how do we assess their hydration status, obviously through observation and patient interview, and doing a physical examination that involve daily weights, assessing their vital signs, and of course we can tell a lot by their hydration with diagnostic testing such as serum electrolytes, a CBC, osmolality, urine specific gravity. So these tell us a lot about our patient's hydration as well. Again, looking at the lifespan considerations when we kind of assess fluid and electrolyte balance in infants to young children, and going across the lifespan then to children and adolescents, pregnant women, and of course fluid electrolyte balance in the older adults. So make sure you go over that and conclude that assigned amount of reading, because there may be questions on that, and let me know if you do have any questions. Okay? Alright, so what we'll do now is we'll go over those practice questions that has to do with fluid and electrolyte. So when assessing a client with fluid volume deficit, the nurse would expect to find what? This is very important, extremely important. So think about what is happening physiologically to this patient, and how would you be able to assess dehydration. So is it increased pulse rate and blood pressure, dyspnea and respiratory crackles, headache and muscle cramps, or orthostatic hypotension and flat neck veins? Think about it. And when you give an answer, I want you to provide that rationale to yourself as well, and not guess at these, because you need to know the physiological reason and the rationale behind it. And the answer to that is, which I know all of you got correct, is orthostatic hypotension and flat neck veins. So let's look at the rationale behind that. In fluid volume deficit, there is less volume in the vascular space, which decreases venous return and cardiac output, leading to manifestations of dizziness, orthostatic hypotension, and flat neck veins. The heart rate increases and the blood pressure falls. Dyspnea and crackles usually are associated with excess fluid volume. Headache and muscle cramps are often due to electrolyte imbalances, but not to a fluid loss. I hope that makes sense to all of you. Question 2. Laboratory results for a client show a serum potassium level of 2.2. Which of the following nursing actions is of highest priority for these patients? Well, first of all, in order to answer this question, you need to know what is the normal range of potassium. And we did discuss that in the PowerPoint earlier. And let's go back, and I want you to kind of think about what that would be. And let me look that up so I can tell you, according to your book, 3.5 to 5.3. So we can see it's significantly lower. This patient is suffering from what we called hypokalemia. So what would we do? Keep the patient on bed rest, initiate cardiac monitoring, start oxygen at 2 liters per minute, or initiate seizure precautions? What do you think the answer would be? The answer is definitely number 2, initiate cardiac monitoring. So let's read what the rationale is behind that. Hypokalemia affects nerve impulse transmission, including the transmission of cardiac impulses. The client may develop ECG changes and atrial or ventricular dysrhythmias. Although hypokalemia can lead to muscle weakness and activity intolerance, bed rest is generally unnecessary. Starting oxygen would be appropriate only if the client were in respiratory distress. Make sense? Good. And the client is more likely to experience cardiac arrest, not seizures. In any case, the priority is cardiac monitoring. The client is not hypoxic, so oxygen is not needed. Okay, number 3. The neonatal nurse explains to new parents that infants are at a greater risk for fluid and electrolyte imbalance than our older children. Which of the following parent comments would indicate that further education is needed? Number 1, infants have a higher metabolic rate than older children do. Number 2, an infant has less body water for reserve as compared with an adult. And number 3, infants maintain their temperature by losing heat through their head. And number 4, infants lose water through their skin and they have a larger proportion of skin surface area than older children do. And the answer is, we would want to kind of redirect their thoughts to their statement of number 3, infants maintain their temperature by losing heat through their head. So let's look at the rationale. Losing heat through their head will have minimal effect on fluid loss in infants. All the other answers are appropriate. It's about their temperature, not about fluid. Question 4. A client with a history of alcohol abuse presents with confusion, hallucination, and a positive Chvostek sign. Which medication should the nurse anticipate administering? Well, first of all, you might not know what Chvostek sign is. And that has to do with calcium balance. And what you do with Chvostek sign. And this is a twitching of the facial muscles in response to tapping over the area of the facial nerve. And so that's what that is. So I wanted to make sure that you were clarified and understood what that was. So let's look what the answer would be. Is it number 1, magnesium sulfate, number 2, potassium chloride, number 3, insulin and glucose, or number 4, sodium bicarbonate? And the answer is magnesium sulfate. And let's look at the rationale behind that. Positive Chvostek sign indicates increased neuromuscular excitability, commonly associated with both hypomagnesemia and hypocalcemia, often seen in people who abuse alcohol and who are nutritionally depleted. Additional manifestations of hypomagnesemia include confusion, hallucinations, and possible psychoses. All right. So administration of magnesium sulfate helps restore magnesium balance and neuromuscular function, and the symptoms presented are not those of potassium depletion and the need for glucose and insulin or sodium depletion. All right, class. This pretty much concludes our lecture on week 7, day 1. That is concerned with the concept of nutrition and our exemplar of abnormal versus normal nutrition, and then of course electrolytes as well. So please be sure that you read these over carefully, okay? This one that I just cannot stress how important is about fluids and electrolytes, because these are very frequently the types of patients that you're going to be caring with, and you need to understand what is happening with these patients, and you need to be able to look at labs and analyze them and determine what's happening with your patients. All right, so thank you so much for your attention, and I appreciate your dedication and your enthusiasm and eagerness to learn this all-important stuff, because you will build upon this information as you continue to move through the curriculum. So enjoy, and again, thank you for your attention.